You're listening to the Physio Matters podcast in association with Choose Health, and this is session 38. Welcome back to the Physio Matters podcast. I'm Jack Chew, and unfortunately you're stuck with just my accent today and of course our guests, but you will not have the team weighing in with their opinions. But thank you for listening to last month's episode. It ended up doing very well, far better than our usual podcasts with the team where we do a bit of a summary in January. Obviously they naturally get a little bit less. Everyone's warming back up in January and we don't touch a clinical area. But talking about the NHS at such a pertinent time clearly has caught your imaginations, and mostly positive feedback. And generally speaking, when we're touching on such difficult areas, it's bound to be that a lot of people didn't agree with everything. And so it begs the question, if you feel you agreed with our positions and the open way in which we found ourselves discussing certain issues, then please do... not necessarily get in touch with us, I don't think that's necessary, but have a think about how you can mobilise that position. How can we find ourselves standing for something as well as against other things? How can we advocate for a sensible, pragmatic solution to the NHS problems as we see them without going for the simplicity that exists between scrap it and simply it needs more money, it's fine. And I think that's a real key area in which, as you can tell, our passions lie as a team, and it really sits well with the ethos of our company. So if you feel you want to do more on that, then hold people to account, hold us and other organisations that profess to represent a message within physiotherapy, but also try and think who's speaking sensibly about this in a political forum, who's peddling a rational and reasonable middle ground, who's just ranting and raving, and who's dismantling silently. We need to hold each other to account just as we do professionally. We want to try and take that out into society and try and rally a voice on what we are considering or think we have got a sensible middle ground. As many of you will already know, we are fan funded, and you'll find us and support us on patreon.com, and well worth mentioning this month because we have a £1,000 course with Toby Hall, previous Physio Matters guest, to give away, a series of weekend courses with Remedy Physio, who kindly supports our work. And this is an 8-day course, a full manual concept certificate, spinal manual therapy, Dr. Toby Hall, 1st to the 4th of April. And 10th to the 13th of June, so 8 days in total, worth £1,000, already sold out, but for this one place that we're giving away. So an absolute, it's an incredible prize that's going to go to one of our patrons. Just to give you a perception of who keeps us ticking over, we get an average of about 24,000 downloads of Physio Matters on a monthly basis, and we have 26 patrons that support us to keep that fan funded. And so a very small percentage of listeners that do support us. Now, I'm not going to play a tiny violin, but of course we'd benefit from that being more. And if you want better and more regular content from us as well, or for us to diversify and start reaching out to putting together some more patient-focused material, then certainly our Patreon account is where you can support us. So anyone that gives to us on Patreon, We'll go into the prize draw for the Toby Hall course, and it would be, of course, much appreciated. There's no obligation to hang around for a certain amount of months, but we know what we're getting then, and we can sort of plan and budget as to what we can put together. So certainly hang around at the end and we'll tell you more about that. And as per usual, I'm waffling already. I want to get straight into our next episode, which is just a phenomenal conversation that I had with a phenomenal person. Absolutely privileged to speak to Neil Langridge on today's episode, who is a physiotherapist and first, known by many as a manual therapist, has taught courses in manual therapy for many years. And we talk about that journey from how his thoughts have changed in the interview. So I won't hover too much on that. But it's worth mentioning that mine and Neil's conversations over the years have they've varied quite widely. We've had some positions in which we've found ourselves clashing, especially in short form over Twitter or social media, feeling like our positions would be less aligned than they were, partly through to misconceptions, miscommunications. But I think our now friendship is testament to what the power of conversation can have when people are simply sharing ideas rather than looking at the individuals and making assumptions based on them. So we've always had a dialogue that has been progressive, and we found ourselves far better aligned than we ever thought we were on both on all sorts of topics, from manual therapy through to critical thinking and reasoning, and also the progress and the plan for how the profession can move forward. So it was a delight to get Neil on the podcast. Hugely thank him for his time. And thank you for listening to what is, again, a longer episode. And towards the end of it, it really finishes with a bang with regards to our personal evaluations and what we need to do to move forward beyond the false dichotomy with regards to things like hands-on, hands-off, and the use of manual therapy and the use of certain tribes and groups and specialist silos that exist in the profession. And that's really well worth holding on for. So you might need to take this one in a few chunks, but please do hang around, and hope to speak to you at the end, and I'll let you know where to get hold of Neil and some of his future courses, which are absolutely phenomenal and consistently. He proves to be, time and time again, a leading light in contemporary musculoskeletal practice, regardless of how much he does or doesn't use his hands. So I'll see you at the other side. I'm here today with Neil Langridge, and I'm delighted to get Neil on the podcast. What Neil doesn't know, and this is where I can come across as wonderfully stalkerish, is that heard of Neil for a long time, but also heard Neil speak a couple of times at HES conferences, and had friends and colleagues go on courses of his over the years. Now, when we were prepping Physio Matters, he was on the hot list, and having heard Neil speak a couple of times, I basically realised I was completely underqualified to discuss things with him without coming at things as critically and as appropriately sceptically as I'd have liked. We went through the motions, and I took some lower hanging fruit for a while, and eventually I felt brave enough to sort of go toe-to-toe. Now, this won't be combative, and we've realised that over a few things in which we've agreed and disagreed with over the years on social media and across, having now met him a couple of times in person. And so delighted to bring Neil Langridge to the podcast to discuss all things manual therapy, mainly in terms of how it's applied into practice, because that's where the important stuff lies. That's where we've found ourselves certainly agreeing when we've chatted off the microphone before. Now, I could give a huge and garbled introduction. I probably already am doing, but I'd rather pass it over to Neil to introduce yourself, and thank you for being on the podcast.
Well, thank you, Jack. It's a real pleasure to have the opportunity to chat to you. So, briefly, I'm a physiotherapist working in the south of England. I've qualified 22 years ago. I work in a number of different clinics and lead a number of different teams from a musculoskeletal perspective. I guess my conflict of interest would be that I teach on what you would be regarded as manual therapy courses. Exploring that as a bias already, and conflict of interest, I need to obviously make sure the listeners are aware of that. And I've been involved in teaching on university courses that are linked to MACP membership, etc.
Okay, and so what's interesting immediately is you've said there courses that are regarded as manual therapy. Now, I know the basic amount of evolution that's gone on over the years, where I would find myself completely agreeing with that synopsis a few years back, where they were heavy in that, whereas certainly am I right in thinking your journey as an ESP, as a consultant physio and as an educator, have meant these courses are and basically the integration of manual therapy into a more complex system? I'm sure they always were to some extent, but I know even the wording of your courses have gone that way. Is that a fair characterization?
Very, very fair. I use it now, and I describe it to facilitate rehabilitation. I guess in the initial phases, when I learned manipulative techniques, or classically known as mobilisation techniques, they were taught and used in isolation. So if I think when I first qualified, life was relatively simple. Because we were treating patients in a mechanistic way. We used manual therapy, exercise, which includes strengthening and stretching. We would friction patients, stick machines on patients, put patients in hydrotherapy pools and put them in gyms. Mm-hmm. And we would just hope that one of those features would fit. And I think most patients I saw would receive some sort of manual therapy. And what basically happened that some did well with it, some did poorly with it, and some had no change at all. But there was a blanket approach with the assumption that this would be helpful. And over time, as you rightly say, that I've tried to integrate it and link it more effectively into retraining and improving patients' capacity and patients' functional reablement back to whatever challenges they're trying to achieve and get over. So in essence, it has progressed and changed. It's narrowed, and I think the belief about what it actually does for me has narrowed significantly. And I hope I'm able to give a fair clinical rationale about what that actually is.
I'm sure we'll get to the meat and the bones on that in a little while for sure. I think it'd be useful for us to not necessarily skip whole chapters, but also point listeners towards a couple of things that both of us have done on air before. Yourself, you chatted to Adam Meekins when he was doing the NAF Physio podcast fairly early doors, and it was a lovely conversation. And for a couple of reasons, you laid out your case in which he found himself surprisingly agreeable to, because I think it's easier to fight against straw men, and he was open to the fact that you presented a fairer case, as well as it being a useful thing where there was a meeting of minds to some extent, where bygones were bygones and hatchets were buried, which was lovely as well. And so there's that I would point listeners to, and we'll link to that, of course, in the show notes. But also, I spoke a little on manual therapy in our first bonus episode, which went out on the PT Pintcast, an American student broadcast, which I understand you listened to. I remember we spoke about it a year or so ago when it came out. Now, it doesn't mean we can't talk about those things, but from what I can gather, we agree on more than we disagree on these topics. So it'll be nice to get into the search through for things than potential issues that we might not agree on. What I'd like to start off with, something that and do correct me if I'm wrong throughout this, but I feel like my approach can be simplified into the fact that, and not just in manual therapy, but if we understand the mechanisms as best possible, we then apply a clinical reasoning framework and then make sure that the application at the patient front line, those three steps tend to give a good rationale for application for any modality, and I think that from what I gather, we do find ourselves agreeing on that. So from that starting point, if you don't mind, I wondered if you'd chat to me about what are the best understood mechanisms for, say, the three main manual therapy techniques known about, which is mobilisation, manipulation, and less so but massage.
Yep, and you're absolutely right about selection and clinical reasoning. I think it's worth touching on that first, and how I would go on to choose and select some of these treatments and integrate it into a treatment episode. So the first thing to consider for me is why a patient is there and their barriers to recovery. So I think Adam actually uses this pyramid, and I think it's an escalation of care pyramid, and I couldn't agree more. Mine would be around reassurance, and if reassurance works, fantastic, then they're empowered to continue with their care and recovery. That might then require some specific advice and guidance, and that's something that we do all the time. If that then doesn't really allow them to move forward, then you might work on some specifics in terms of exercise, functional retraining, capacity retraining, and looking for the barriers around that. And then you get to a point where if that's not worked, you've got to consider why that patient is still failing to recover. And that might be a misdiagnosis, misprognosis, missed pathology, an overt proposal of your beliefs, the patient doesn't believe you, the patient's not on board, miscommunication, or the patient has some psychosocial, emotional anxiety barriers to recovery. And lastly, you might find there's a biomechanical reason that they're unable to move in an effective way to allow that functional reablement to therefore be successful. And if you take that parameter to say, look, I think there's a biomechanical reason, i.e. I'm trying to retrain a movement and they're unsuccessful in that, you can consider some hands-on therapies to try to improve that experience. And there are basically two main mechanisms, I believe, that hands-on therapies will enhance towards functional retraining. One would be a proprioceptive experience, improved proprioceptive awareness. And it's quite beautifully described as body awareness by authors that use the rubber hand illusion that shows you how plastic the experience of proprioception and body experience actually is. So your awareness of a body part from a proprioceptive perspective is enhanced through acknowledgement and through feeling and through awareness, visual feedback. And proprioceptive deficits, such as a sense of balance, a sense of tension, a sense of body awareness and kinesthesia, joint position sense, becomes poorly represented with injury and ongoing pain. So the first mechanism, which I'll talk about in a bit more detail, would be proprioceptive awareness. The second would be modulation of the pain experience. And that integrates with proprioception, because if you reduce the pain experience, you then, in essence, will enhance a proprioceptive awareness. You're changing the neurophysiological responses of different receptors to enhance a movement pattern. That then moves into improved patient perspective. And once you link those three together, hopefully then you can enhance a movement pattern that can be employed on a repeated way towards a functional gain. So if we think about proprioception, we have cutaneous and muscular afferents that supply information all the time to our nervous system. And those elements can certainly become deficient. If you look at somebody who has what we would classically describe as a stiffened spine, they would be hypertonic. And there are numerous reasons why someone would be hypertonic, from emotional to tissue adaptive to trauma. And if you work out what the reason for that tonicity is, and if it's an emotional reaction, it's a hypervigilance, then you're going to address it with some of those approaches to deal with that barrier. If it's postural adaptation or long-term tissue adaptation to poor loading, then you might want to address it through exercise. But if that fails, you might then want to address it through some hands-on therapies that will enhance the proprioceptive response. So you can actually apply techniques that will stimulate cutaneous and soft tissue afferents in numerous ways. Just putting your hands on someone will do it. If I think about my son getting taught by a golf professional, looking at, say, trying to improve his rotation, and you see the professional showing him, but in the end the professional puts his hands on certain body parts to enhance his understanding of where his body should be. And I guess that analogy fits with something like mobilizations with movement, which I don't believe are mobilizing anything. It's the patient that's mobilizing. You're just enhancing that movement experience through an application of your hands. With manipulative techniques, for example, quick thrust techniques that are specific to direction and specific to force. Muscle spindles react to these specifically, especially with fast-acting, short-duration techniques. And they've also been shown that if you apply that technique close to the area of dysfunction, you'll get a greater muscle spindle response. So therefore enhancing that proprioceptive awareness.
Area of there's a few things there. The area of dysfunction being area of symptomology, or are you going back far enough as to suggest area of dysfunction being something visually or palpably noted?
So dysfunction, and we might talk about a little bit about sort of things like pivoting and motion palpation. Dysfunction, I guess, really in the strictest sense of the term, is something that's not right. And us as therapists then build a clinical picture about what that not rightness is. Mm-hmm. So, for example, that's going to be built up through the patient narrative, through observation, through other testing, through your clinical experience to make a fair clinical judgment. And when it comes to tissues, you're looking whether it's adaptive, maladaptive, whether it's actually doing what you need it to do. So I think about palpation, well, it's enhanced by your clinical rationale. It's not just a singular test. And as a singular test, it would be useless.
I mean, I think later in the chat, we'll go there in a little more detail. I think you've got some really interesting things to say on that. Before we do, though, where you were talking about that almost hierarchy of treatment and things, I've also understood that, well, the way I understand it, and it's something that I imagine we'd agree on, is that these things are incredibly malleable. So sometimes the laying of hands is the essential part of a reassurance process. It's not just the verbal reassurance that can occur. Laying of hands, especially in an assessment process and getting someone to feel confident, and also the therapist, even granting permission for a patient to be assessed in that range can sometimes be effective reassurance, because the patient's thinking, well, I shouldn't go there because it's dangerous. The fact that as clinicians we're comfortable with them going there can be an effective reassurance technique. So these things aren't just, I won't lay hands unless I need to. Sometimes these things are more malleable, aren't they?
Hugely. And if I go back to that original, that it's proprioception, pain modulation, and patient perspective, it's the emotional response of connecting hand that can be perceived and interpreted in numerous different ways. And to reassure someone through a movement is going to be doing a neurobiological effect. So there's no getting away from that. How the actual interaction and the actual physiology of that, I'm not entirely sure. But if you can reassure someone through a movement and then they can see that movement is achievable, therefore that will be endogenous. That has an outcome that is advantageous.
Do you think that there is I mean, what you're saying about proprioception, and I know that some of your PhD work was in and around sort of what the muscular changes and trying to, for want of a better word, profile patients into certain techniques. Do you think there is a degree of almost spatial neglect like you would see in truly neurologically deficient patients? Is it a subtle version of that where they're starting to use that limb or a deficient limb, if we call it that, in a certain way similar to those cases?
Yeah, I'll just quickly correct you. The doctorate was more on clinical decisioning and back pain rather than the actual physiology of...
My mistake, sorry. Yeah.
But no, it's fine. So yes, I think there is a deficiency in the way that patients actually perceive their body in space. So through the mechanism of injury, ongoing pain modulation, maladaptation, poor positional loading capacity. So patients don't wish to take load through an area of the spine or overtly take load through a spine. They fix themselves in different ways. I think that leads to an inattention because they lose variability. And if you lose variability, then you are in a fixed position. Therefore, that then leads to poor information being picked up by the nervous system. And so what we're trying to do with therapies, in my mind, whether it's exercise or advice or hands-on, is to engage variability to movement, to give the system the ability to be able to predict, to be able to deal with changes in activity, changes in function, changes in context, environment, therefore allow them to do things normally. That's when overt advice, such as you must never do this, or you must never do this, or always do this, or always do that, is actually unhelpful. It's believed to be helpful to sit in a certain position, or always bend your knees when you pick something up. But actually, what that's doing, it's reducing variability.
Yeah, absolutely. No, it makes sense. Now, just to backtrack just slightly and say, with mobilisation and manipulation, we know that there are quite fleeting but tangible and measurable changes in muscle tone around that area. Is it smart for us to just dance over some of the things that we used to think happened and now no longer do? You know, it may be useful, not instead of saying what does it do, what doesn't it do? Because both I think it'd be interesting for the listeners just to cement some of those things, but also I'd like to just touch on your journey away from that understanding, because you're one of only a handful of people that I feel has migrated away from the biomechanical dichotomy sufficiently to marry up with where the evidence took us.
Yeah, so I used to believe that I mobilise tissues. So that's the first thing that I don't do. I don't think I mobilise anything. I produce a mechanical force into tissues that changes an experience of proprioception and pain. I don't move bones. I create tension through tissues that is picked up as mechanical force. It once again modulates proprioceptively from a pain perspective. I used to think I could move things up and down, which was wrong. I never really believed I put anything back in. I used to think I'd release things.
You stopped short of that, did you?
Yeah. I think thankfully I stopped short. I used to think I might have released something.
Okay.
And because it's quite altruistic to believe that, I've actually done something. It feels interventional at times, and it makes you feel better about yourself when you feel you've done something. But you've got to try and move away from that. I always give the analogy when I compare the story, between mobilisation theory and manipulation. That, I've taught manipulation, I've taught mobilisation numerous times, and I've never seen anyone high five their friend after a 30-second mobilisation, but I've seen it after they've manipulated somebody which they perceive as successful. So it's so important to the clinician to feel good about yourself.
Well, you get the double handshake from a patient. Yeah, you get the eye contact. Potentially, at best, you get a subtle tear in the eye of appreciation for the unlocking or the fixing of the magic crack.
Yeah. Oh, yeah. There's a huge amount of that going on. It's a double placebo. It's a patient and a clinician placebo. We all want to feel good about ourselves with what we do, and it gives an air of confidence to the patient, which can be negative or positive.
Sure. And I think that's what's amusing as well, is that I never lie to anyone and say, doesn't matter what you understand of it, it's still incredibly satisfying to just get that, to get a cavitation. It's like it's I think we're all subtle crack addicts. That's how I see it.
And there's a massive so what about that. There is such a and what I'll always say is that it's got to be housed with relevance, and you've got to show that there's a clinical advantageous outcome to this. If you just pop and click people and think that's going to be useful, then you're really mistaken. And it's got to be housed in a very strong clinical reason, patient-led outcome model, where you can really link what you've done to something that has an endpoint. And if you can't, then you shouldn't be doing it.
I remember we're going back a few years now, and so there's a very strong chance and almost a suspicion of mine that you'll have moved past this reasoning at that point where I remember you giving a lecture in which you were saying, when we manipulate, we get tonal changes in the musculature where if there's a underactivity, it'd almost normalise, and if there's an overactivity, it'd then dampen, and therefore that gives a nice window in which we can give good quality, functional, sensible movements within that window in which you reinforce a useful muscle patterning. Now, I remember sort of seeing where you were going with it, but it did admittedly feel quite ambitious in a sense that you would be reinforcing something sufficiently within that time frame that we knew of in the literature. Now, I'm throwing that out there and admitting it was a while ago. Is that something that you want to either elaborate on, or is it something you've moved from?
So you're right. That's definitely one of my proposals, is that you have this tonal change, which allows then you to reinforce movement very, very quickly. And when I've again looked at the literature surrounding body awareness and proprioception, you can change someone's, again, I go to that rubber hand illusion paper, those papers surrounding that, which the listeners based around is that you can't see your own hand, and they have a rubber hand, and the researcher will rub both your index finger and the rubber index finger at the same time, so you experience both. They then stop rubbing your own hand, keep rubbing the rubber hand, and you still experience that sensation because you're visually looking at it. So it just shows, and you can do that within a very short period of time. And so it shows you how the plastic nature of body awareness to me. So I think if we look at, let's take something that happens in practice. Let's take a pelvic tilt, for example, trying to retrain someone's pelvic tilt into something different that offloads and changes their pain experience. I think we would say in many cases we're able to at least make some inroads with that in some patients within that 15, 20 minutes, half an hour treatment episode. So if we can do that, and you can spend 2 or 3 minutes on manual therapy that gives you a greater opportunity to do that more successfully, that for me would be time well spent. Plainly, if there's no carryover into an improved awareness and improved pattern straight away, then I would drop the manual therapy and look for some other way to teach the patient to move differently. And of course, use numerous ways to teach: feedback, encouragement, whether visual awareness, hands-on. People use all sorts of different things. But I think from my perspective, I'm still along those lines, that if you use a technique that enhances or changes muscular activity, albeit for a short period of time, within that treatment episode, you're still able to improve their patterning.
No, that does make sense. And as I suspected, with elaboration, some of the concerns that I had around that time and might retain certainly get alleviated. That makes sense to me. There are some fair critiques and criticisms of that, even that approach, which we'll come to, and some of them good, some of them daft, and I think we'll come to that. That's the plan. with just to touch on it, although it's not something that we need to hover on, and if the listeners really want more of it, we can go back to it with possibly another guest. Is with massage, then the soft tissue techniques, and you mentioned the age-old frictions that just make me cringe when I think about what we used to do to people with that. But generally speaking, just to hover around the what doesn't that do, I know Mike Callahan's work as well as many others in the late 90s, early 2000s thought to have debunked a lot of the understanding around the circulatory changes or the breaking down of adhesions and the actual mechanical changes to the tissue from it. Now that still lingers for various reasons, including in our own profession quite deeply. So I've just named a few. Is there anything else you feel needs to be clarified on that?
I would entirely agree with you. I don't have any belief that I'm breaking any adhesions or significantly changing any circulatory responses. So if you think about massage and mobilisation theory and manipulation, you're looking at two very simple start models. One is a pain produces pain model, which might be used to be described as counter irritation. Pain, leading to a descending inhibitory response. So you produce a pain response, which then produces an endogenous response. Massage would be, along with maybe some more physiological techniques that are non-painful, fit the large afferent classic pain gate theory responses to dealing with a pain experience. It would be endogenous as well, in the fact that it produces non-specific treatment effects, which we describe as placebo, which would be one of the other main mechanisms around some of these techniques. Patient expectation. If you tell a patient, I'm going to give you a massage, this will be relaxing and soothing, and we'll chat about things for 20 minutes, and they have an opportunity to communicate while they're having that treatment, and it's very relaxing, then of course that's going to be, in terms of non-specific treatment effects, useful and advantageous. So my belief is that really what you're doing is a communicative technique that allows an endogenous response that is neurophysiological, but is really quite emotional as well for those patients.
For sure. And it's very individual, isn't it, about just how people would get that response. If they're wanting a deep rub from any clinician, and they get gently tickled in some sort of other more mild way, then you're never going to get that response because you're not meeting expectation. And that's where we'll probably come to it later in the conversation, or remind me to drag me back there if we need to, about how that can be problematic, where we might just not necessarily tackle some of the misconceptions, and therefore we might not be the ones saying, oh, we're breaking down adhesions, but if that's because it's a deep-rooted understanding in society, it's kind of probably a smart move for us to move them away from that mentality, because in my opinion at least, it does to some degree perpetuate this myth of fragility, the fact that a clinician could alter your tissues in such a way, in some meaningful way, with their bare hands in a few minutes. Kind of makes. I've even had patients that are worried if they bump into a table because they're that easily malleable. Right?
Yeah, absolutely crazy that goes on. I can't see. I've never read any research, and it makes no physiological sense. I mean, what we've got with patients and some of the techniques and the therapists, the problem is not the techniques. The problem is the therapists. The problem is the therapist's interaction with that technique and how they deliver that to the patient in the context that they deliver it to. And we can talk about the argument about disempowering patients through some of these, either now or a bit later, and that's a highly relevant question.
Well, we'll come back. Yeah, actually, I think it's super important, and to reassure the listeners now that might want us to go there now, we will come back to that, because I think it's a super important one, because I think, and another place where I think we agree. But just before we do, there is different schools of thought onto whether it even matters how manual therapy works. So all of the last 15 minutes or so we've just been talking about it. Yeah. There's a school of thought that sort of throw their arms up in the air and say, who cares how it works if it works? And then there's another, which admittedly is a camp I fall more closely in with, which is this idea in which if we understand the mechanisms at least well enough to communicate them with patients, it does seem to change our interactions, and at the very very least, it's more honest. And I think if a patient asks us something, I think it's a very helpful thing, unless it's immediately deleterious to them, such as being too frank about a red flag and scaremongering to some extent. But generally speaking, I think it's a very intellectually honest thing to do, to elaborate things as closely as we can to the truth as we understand it. Now, where do you sit in those sort of schools of thought?
I don't believe that clinicians should be applying any sort of technique that they can't demonstrate is clinically advantageous and triangulate that in a number of different ways. So simply, they should show that patient outcomes are enhanced through those techniques, and that should be a patient-led, patient-reported outcome. They should be able to present a sensible rationale based on the clinical evidence around those techniques, but also the biology, the neurobiology that would potentially support those clinical proposals. They should also be able to provide a fair and clinical critical review of those papers and that research, and acknowledge their own clinical biases, which every single one of us has. We like certain techniques, we like certain treatments, and that leads to an air of confidence, and it also leads to the ability to offer that explanation to the patient, because you do it numerous times and it's quite well worded. And that then leads to an air of confidence for the patient as to the fact that you seem to know what you're talking about. So, so for me, it based around what I use the term all the time, clinical common sense. If it doesn't make clinical common sense and doesn't have obvious patient outcomes that are going to be clinically advantageous towards their goals, then it shouldn't be used.
No, that's a completely rational red line, isn't it, that you've given yourself as a clinician and therefore would want to teach. It just reminds me to come back just slightly to your, and I know it doesn't need to be this is your life, but equally your journey from a biomechanical model through to this more person-centered approach to still laying hands, but within a what I would argue a much more sensible, rational sort of framework. Was that difficult? Because I did mention that I can only, if someone held a gun to my head, I wouldn't be able to reel off that many names of people that I feel have taken the journey you've taken, and I do applaud that without it being too much of a brown-nosed moment. But it's important, I think, to just recognise that is a difficult thing, particularly for people like yourself who forged a career and a reputation over these things. You were known as one of those guys for a good while, and sometimes that's a stench that's hard to wash off, and so to some degree shouldn't be a stench, because that's evolution of the practice and the profession. You got anything to reflect on that journey? Yeah,
hugely. If I look back when I first qualified and started getting myself involved in courses, you have to remember that was the days before the internet. So that was the day before exchange of information. So the only way you'd really learn something, or you feel you learn something, is through books or going to listen to a guru. So I would guru chase, and I would put myself on as many courses, and I really believed what they were telling me was true, because I didn't have any other counter view to offer them. I'd no experience. The books didn't really make a lot of sense. They were a bit dry.
And Physio Matters didn't exist then, did it? I mean,
exactly.
How did we cope?
How did we get by? So I would basically trot out the belief system that I'd just been fed. And many times I'd see that it would work. And the reason it would work was I would look for these problems in patients. So if I went and did a sacroiliac joint course, everybody had a positive stalk test, and I could literally feel my thumb moving up, because I wanted that to happen. The reason I wanted that to happen is because then I could do something, or I felt I could do something. So over time, I got led down this approach, and that was all that was offered to me. But over that time, what I've come to realise, the more that I put my head above the parapet, started teaching, and people would be critical and ask me questions, which would be fantastic, I had to go back and think I couldn't answer that, or I didn't know I couldn't give a reasonable explanation. That was complete flannel, and I was fluffing it. So I'd have to keep reading and look in different areas of the literature to build up my own rationale, which not only for teaching, but my own self-being about actually staying as a physiotherapist. Is this something I want to do? Because I can't just keep giving this very, very poor answer that has no depth to it, and I'm not able to talk clearly or freely about it, and I'll run out of things to say within within 10 seconds.
Are we just fortunate that you weren't dogmatic, though? Because some people just double down. Sounds like you met an enlightenment period in which you decided to be true to yourself, and it just felt intuitively unpleasant, whereas others have sort of doubled down on it and thought, no, it's not that I don't understand the literature, it's the literature doesn't understand me and my patients. So I think I understand why you're saying what you're saying, but I think you're almost playing down, because not a lot of people do what you did.
Well, it's down to imposter syndrome, Jack. That's what it is. You put yourself into the positions I get into, and you think, crikey, I shouldn't really be here. And the only way I can ever give myself the confidence to be in these situations is to empower myself with as much knowledge as I possibly can. And that's not to say I've got more than anyone, less than anyone, or I know everything. It's just that it gives me the confidence to work with patients or talk to clinicians or teach or be in a position to teach, which is a very humbling experience to think that you're in a position where people want to come and listen to you. And if you don't have that sort of humbleness about you, then you really shouldn't be there, because you won't continually criticize yourself. So it's not a choice. It's probably it's a behavior.
Absolutely, no, and that's great. And there's such an endearing charm to that, because as I mentioned, a lot of people don't go there. And I again thank you for doing it and also sharing that with us. What's tickled me a little bit there is with the SIJ course is a classic for this next question. But manual therapy sort of historically, and you'd argue currently, linked to manual assessment such as motion palpation. I personally, and I'll again plant a flag, and you've heard me speak of this, is I loathe the notion of magic hands and the idea in which that matters to the nth degree. And we've kind of talked about that, but what we've not talked about is a malicious flip side to that. A suggestion that feel doesn't matter at all, and that we can't trust his eyes, we can't trust our hands in any which way. Now, I see counters to that approach in all walks of life outside of manual therapy. I see people that have trained sensory skill that I don't have, and I see people that are clumsy, and I feel people and students, let's argue, not to bash students, but people that have got untrained hands to handle a neck that's hanging off the edge of a plinth, and we can all tell a good and bad sort of experience there. So I always make an argument for a sense of competence when it comes to feel, and that's me admitting that there's somewhere in between, probably nearer the side that away from the magic hands, admittedly, but equally I don't go as far as to say it doesn't matter. So where's your positioning on the whole feel debate, and how do we square that circle in contemporary practice?
It's a really good question, and I think if you look at MSK, musculoskeletal practice, there is no area of practice where one test tells you everything. And in fact, the choice of tests is based upon the patient narrative. So let's use a test that does require feel that's in the periphery. A Lachman's test, for example, is a good example.
Yeah.
Where you use that test and you're looking for end feel to make a judgment as to whether that patient has a deficient ACR. But you wouldn't necessarily do that test if the patient hasn't had a history of trauma, is maybe a younger person, and isn't going to given you any signs that their knee is giving way, is locking, etc. So if there are no signs for that, you wouldn't necessarily choose it. However, if somebody said it's a 24-year-old twisted their knee 4 weeks ago and their knee's now giving way, you would sort of suspect that test is going to be useful, and you might suspect what the outcome might be. So that you then apply that to the spine, and you hear the narratives. You start thinking about patterns. The patient says, "Oh, I have problems with twisting, turning, bending, getting out of their chair, standing for long periods of time." And all I do is I work in a pattern. So if it sounds like an extension or a compressive pattern or an opening pattern, I use that to start thinking about how I'm going to approach improving that function. And therefore, I then watch them do some of those movements. I then make a judgment as to whether they do that well. And that's normally patient reported, because patient says that feels okay or that doesn't feel okay. And if something doesn't feel okay, doesn't look okay, and there's a history of actually not being well managed throughout their normal lives, you then say, well, what are all the barriers? Let's take flexion of the spine. What are all the barriers that would stop that individual from flexing effectively? And you think about those. Well, the way they move, their confidence in moving, their tissue adaptability, their hamstrings, their movement through their hips, their movement through their spine. And you test those sequentially based on a priority status. And if it looks like the spine is one of the main issues that's stopping them do that successfully, you then go to testing the feel of that spine with all that background knowledge behind you. And then you just move it and you feel the tissue adaptability. Now, I'm not someone who believes you can feel single articulation changes. I don't believe that at all. So I look for patterns. So maybe there is a lower lumbar spine is tighter, the mid lumbar spine is tighter, the upper lumbar, the thoracic looks tight. And it might be 3, 4, 5 segments that seem to be lacking that capacity to move in that direction. And I would then palpate and move those tissues, mechanically stress them, and make a judgment call based upon all that information as to whether intervention is relevant or intervention is not going to be relevant here.
Absolutely, no, that makes sense. It's in just to paraphrase then, and hopefully fairly, it's the overt rather than the subtle. It's the movement away from the idea in which subtle changes, like we were joking around with the SRJ, it makes no sense. Whereas someone who's holding some rigidity for whatever reason, or it looks to be full segments, sort of cluster of segments that seem to be moving, what we would argue suboptimally, or just doesn't look comfortable, shall we argue, when they perform functional tasks.
Doesn't look comfortable, and the patient doesn't feel as comfortable.
Sure.
Most of the tests I do are patient-led feedback. I don't do that in silence. How does that feel for you? That feels, if they say it feels tense or it feels tight, that's a proprioceptive awareness. That's really helpful for me to know. And yeah, the subtleties, I don't work in subtleties. When I work with any of my team or I'm teaching, I talk about likelihood. What is the most likely? If you're looking for something you're not sure about, it's probably not very likely. So look for things that are obvious and work backwards from there.
I always find it amusing, as you know, to find comparisons from clinical and life itself. And I always think if you and I was too bothered about subtleties, we'd have never have had any productive conversations over the years. Neither of us bother much with subtle. Let's look at the overt stuff. So that tickles me. I think it does make a difference there. Does the critical but rational reading of the literature support the use of manual therapy more for certain conditions, certain body parts, certain presentations, or some would argue even certain people? I know that's a very tricky question, but are there any sort of examples? You can feel free to, if you want to welcome sort of case studies of a kind, to just give a profile of situation where it is or isn't indicated.
Okay, so the opening response to that is that tons of the literature is really biased. Methodology is poor. If you're interested in how, maybe cats respond to manipulation, you might find some information. But you have to try and extrapolate some of those outcomes. And if you think, you look at some of the papers that look at cadavers and wires and models, and unfortunately, the big problem is it doesn't relate to real life. So you have to try and take those with an enormous vat of salt in terms of taking that forward. Sure. You have to look at the bias about the authors. Most of the authors are people who are involved in manipulation, or a special interest group, or a profession that is manipulative based. So if you look at that leads to an obvious bias. However, the main features is what I've said. That if you look at the sort of blanket overview, that if you use manipulative techniques and hands-on techniques, you can modulate a pain experience. A pain pressure threshold is used in clinical patients, so patients with symptomology, and we've seen that there are tonal changes with patients with symptomology and without. So that's, for me, is a fair overview. If you look at some of the papers about proprioception, Bremain did a really nice paper on, and I think it was a PhD thesis that looked at pelvic tilting and looked at the improving proprioceptive awareness with very fast vibratory techniques to increase the sense of lengthening for muscle spindles. And interestingly, with patients that had low back pain, their proprioception improved. The patients that didn't have low back pain, so the control group, their joint position sense worsened because they had overt information across the muscle spindles in the lumbar spine.
The theory being that they had more than they needed, and it wasn't useful to that system. It wasn't
useful. It was there for a very short period of time, obviously, right. And that's the other thing that you see. You see some papers that say, well, these changes lasted 20 minutes. Or another paper I've seen that said that some of these threshold to detect passive movements lasted a week. In the end, is it clinically useful within the environment you work in? So if you see somebody and you've got half an hour with them, and you do some work with them within 5 minutes, you know those changes are going to last 20 minutes. Well, there's 20 minutes to start working within that movement pattern. If it only lasted a minute, it's probably not very useful. But if it lasted a treatment episode for me, then I would take that away and take that as something I could hopefully apply, because it means in practice it's useful. Body part wise, generally reasonable research around thoracic manipulation and cervical spine pain, lumbar manipulations and local lumbar spine pain in a certain population. But again, some of these, the reasoning behind their patient selection, their patient cohort, clinical prediction rule for spinal manipulation. Have you ever seen that one?
Mm-hmm. Oh yeah.
See, that suggests that if you have a patient with pain for less than 16 days, who has no fear avoidance, who has a good mobility in their hip and has a stiff spine, they'll do well with manipulation. Well, they'll do well with anything. Probably just do well with just being left alone. And how many times are you going to see a patient who's had pain for less than 16 days? And if you did, what would you do with them? You'd probably say you'll be fine and off you go.
Well, so that's the thing, is that one of the difficult... I think I can't remember who said it, or many people will have said it. It might even have been yourself who said the profile of patient that fits into these clinical prediction rules is the holy grail of patient that everyone wants to see. It's like if you have enough inclusion and exclusion, then there's just this sweet spot where you can tickle their left earlobe and they'll do well.
Well, they're not actually a patient. They're just normal people who shouldn't even be there.
That's just a slightly sore human that woke out of bed and saw a poster. Yeah, I see what you mean.
Achy this morning, I think I'll go off and see my physio, and they clinically predict me and crack my back. Well, thanks. Probably if I just had a bit of walking, I'd have been okay.
Sure. No, that's fair enough. Is there anything that sort of surprised you over the years as to what hasn't done well with it, or it's something that's been a horse that's been flogged, where it's been suspected that manual therapy would be a smart move, and then has proven to be somewhat ineffective? Is there anything that springs to mind there?
Probably in terms of the narrowing down the patient cohort. I think when we talk about back pain or we talk about spinal pain, what we do know is, or what I believe is, that it is a narrow field of the patients that it'll be useful for. These are patients that are failing to respond after normal healing, or for want of a better way to describe, has happened. But the chronicity of patients who are depressed, who don't sleep well, have high levels of sensitivity, anxiety, these individuals don't do very well. They lump these patients into these groups and don't subgroup the individual very well at all. And that's the problem, is that they're not unable to tease out the individual characteristics that we see every day in practice. And they're based on very, very poor mechanisms of pulling subgrouping together. So
you've never really, sorry to interrupt, you've never really, as far as I can tell, this is me trying to, I'm observing and commentating on these things often, and you don't seem to have ever really bought into the old subgrouping and that's often, I talked about your journey. Often people's journey is to do with brings them to subgroups before they find the individual. It's like a smaller and smaller subgroups, and then they realise that these groups are porous. Whereas you seem to have not really you took that chapter out of the book almost. Am I right in thinking you never really bought into that?
No, I never really believed it. I remember speaking at a number of conferences saying, I don't believe in a subclassification. I don't believe it's possible. It's a golden chalice that we're trying to find, and I just don't think it'll happen. And so I really do believe that the individual is the subgroup. It has a number of features from subgrouping that you look at and you place them in a priority order. Then that priority order changes over time. It doesn't stay as it is at the start. What might be really relevant for that patient will change over time. What might be really relevant for you will change over time. In fact, if you use these subgrouping, they'll probably change over time, and it's probably a combination of them all. And that's the problem. If you lump it all together, that's the subgroup. That's everything that physical therapy has to offer. That's the subgroup, because these are the patients that we The variability is the patient and their experience and the clinician, and that comes together into a framework, and that framework is individualized to that patient at that time, and you have to then acknowledge that that could change week to week. You have to be able to monitor that, and if you monitor it through an algorithm or monitor it through some sort of subclassification belief system, you'll get caught out. Patients will fall off that very, very quickly.
Sure. I spoke to Toby Hall. I don't know if you heard that podcast in which we talked more around headache and upper psychogenic headache, and that is an area in which I'm quite comfortable to say that, well, that's certainly the upper cervical and also at the ankle, with regards to how it seems to change sort of neuromotor changes and sort of proprioceptive sense, which would make sense on those areas. But I also then admit frustration when, and I don't like the phrase, but I would argue an old guard then takes that as a kernel of truth and then tries to re-extrapolate that as if it's then going to be a resurgence and it can be applied across the body. That's me again admitting a frustration, but they're body parts that seem to work well for. Is there still, I mean, apart from maybe the ankle as an exception, but is it still the case in practice, as I feel my hunch is that it is, that people mobilise the spine, mobilise and manipulate the spine more than they do the periphery still? And if so, is that a valid use of manual therapy? Is that a fair dichotomy of when to lay hands that seems to be broken between the spine and the periphery?
Yeah, and it always amazes me that we treat them differently. It's morphology. It's like treating the cervical spine differently to the thoracic, and we describe it differently. It's based upon morphology. The whole system, and if we talk about the whole system as a human system, works in patterns and synergies, and suggests they are distinct from each other is a mistake, in my opinion. So how we apply movement to whether it's the periphery and the common sense approach that we apply to movement in the spine should be applicable everywhere. You have certain areas, upper cervical spine, you use the example, has a really high dense number of proprioceptors due to the fact that it needs to balance a heavy head on a wobbly neck. But there are other areas that have less so. And acknowledge that. But in the end, what you're trying to do is create movement, and you're trying to decrease pain. And whether you do that in the periphery or do that in the spine, it really doesn't matter. I think when you talk about mobilization, we need to start thinking differently about, if we talk about PAs, poking and prodding, that isn't mobilizing. That you're not producing more mobility. It allows the patient to feel a sense change to increase their natural ability to be more mobile. It's not you doing it, it's giving the patient the opportunity to do it. And it's exactly the same whether it's periphery, whether you start moving the ankle, you start moving the knee, whether you start moving the shoulder, you are increasing their self-awareness of how to move differently, with less pain, and have a better representation of that movement pattern to allow them to move forward.
Are you comfortable with some of the summaries that Joel Bialowski's spoken of regarding that there's an insufficiency? I know I'm paraphrasing his work hugely here, but there's an insufficiency of force that can be produced by another human unless you strike someone. That if you're already in contact with them, that there is an insufficiency of force to do what we used to think happened. It was one of the hard physics just doesn't marry on to the theory.
Yeah, completely agree. And you go back to that clinical rationale, that triangulation where you take the evidence, your clinical outcomes, and the physics, the biology, the neuroscience to support your clinical rationale. If it doesn't fit, then it should be got rid of. And absolutely right. We can't produce forces enough to actually create mechanical deformation. That's not going to happen. So having that as a proposed model would be incorrect.
No, that certainly makes sense. We'd agree there. It'd be really interesting to hear from listeners if they feel that they want to push back against any of those things specifically, because almost it's like a Newtonian and Darwinian things that we've talked about. And as you hopefully have noticed in our podcast, we try to come at anything we're talking in almost an opposition for. We want to come at it not at its straw man, we want it at a steel man, we want it in its strongest form. And so to talk about some of the critiques that get thrown at manual therapy. There's the good, the bad, and the ugly.
Yeah.
Just you'll have heard them all before, and some will have changed your practice, and some will have frustrated you. What are the strongest and weakest arguments against the use of manual therapy, and what does the evidence say about them?
So let's take a few of those. Let's talk about it'd be a good time to talk about the disempowerment, the passive versus active therapies argument. So again, I really reinforce it is not the therapy that disempowers the patient. It's the therapist that disempowers the patient. Mm-hmm. It's the reasoning that disempowers the patient. So if you use that treatment escalation, and you're at a point where they're unable to move differently. So what is the best way to empower the patient to move differently? What's the best way for them to experience a better movement pattern that you've been unable to achieve so far? So if you allow that to happen, if you do it what's regarded as a passive treatment, i.e. it's clinically the clinician led, it's a clinical intervention through the clinical practice and whatever that might be, that then allows the patient to see they can move differently. Albeit for a short period of time, but you're then going to enhance that with exercise therapy. If the patient can see there's an outcome, can see there's benefit, however, they can see that they're going to be moving forward, that for me empowers the patient to feel differently about their condition. Mm. If you balance that up against continued failed treatment and a patient going round and round in circles, unable to move forward, that disempowers them. And then you'll get asked the question, well, what happens when it goes wrong? They'll just come back and see you expecting you to treat them. If you use that escalation, you say to them, what you need to do is reassure yourself that it's all okay. You need to go through those simple measures that we went through first time, and it will probably be okay. But there may be the odd occasion when it's not. That's the time to come back and see me, and we'll review why you've not been able to move on. You don't say, well, I'll do the same again, because it might not be the same again. Sure. So it's how you communicate when the patient should access care. It's nothing to do with when the patient should have their back popped or when they should have manual therapy. It's when they should access care, and looking at those reasons for why patients don't move forward and naturally recover. Humans are designed to naturally recover. And if they haven't naturally recovered, our job as physical therapists to look for those physical and linked emotional physical barriers to enable that patient to move forward again themselves. If that requires some intervention at some point, the context in which you offer that is the most important thing.
And so you're constantly laying on the expectation, basically. You're helping them to understand what it is we can offer, what it is we can't offer, and the context is very individual in all of those circumstances. With the dependence argument, I think that it's been hard for people, especially staunch skeptics and critics of manual therapy. It's been hard for them to uncouple the actions and the actual interventions from the reasoning or counter-reasoning framework that they've been historically placed within. They've thrown the baby out with the bathwater and thought, instead of what you've just described there, that these techniques are intimately coupled with fallacy-based reasoning, therefore let's rid ourselves of them and use them incredibly sparingly. And while I have some sympathy with it, I think it's lacking the nuanced thinking that will help us as a profession. And it's born this dichotomy of, are you hands-on, are you hands-off? Which is and I know you've even formally debated such nonsense before with a furrowed brow, if I remember rightly. So it's one of that's something that I think we both have sympathy for. That it creates dependence, but as you've just explained very nicely, and I needn't add any more to it. That I agree with you. I think it's the interaction and the therapist that creates a dependence, or vice versa. One of the weaker arguments I would introduce would be the it does nothing argument, where it's like, well, what's the point? It just doesn't do anything. Now that is a straw man, putting it politely, isn't it? That's a fallacy itself.
Well, I always say, people ask me, what are the consequences? If things don't work well, what are the consequences of manual therapy? And I say, the worst thing that can happen in the vast majority of cases is nothing, that you don't do anything. So, and that is a truth, that you use an intervention that is unhelpful. Well, that's medicine. That happens in all walks of medical intervention, where you trial a treatment based on evidence. the clinical evidence in front of you, and it's unhelpful. So then you think about your next option. Now, where that's used poorly is when it's a default that you use it on everybody or you use it straight away. So if you go down that line straight away and use it on every patient, there will be those patients, as I experienced when I first started working, that nothing happens. It's clinically doesn't change anything at all. And in fact, that's then a failed treatment, and that then disempowers patients for their belief in the clinician and patient interaction. So it's true that there are, with poor patient selection, that it will do nothing. And it's also true with poor patient selection that you'll make them worse. You'll flare them up, you'll stir them up, they'll have a poor patient experience, and they probably won't come back, and they certainly won't re-engage with you or physiotherapy again. So I couldn't agree with you more that there is an absolute outcome of nothing with certain patients if you choose to do so.
But the suggestion that neurophysiologically or at a tissue level that it does nothing is the silly part. It can do nothing with the patient presentation, but for people that just are suggesting that there's an irrelevance to the laying of hands is silly, isn't it?
Yeah. I mean, to say, just if you think about the number of receptors we've got in our soft tissues, to say that nothing will happen as you place your hands on somebody, it's one of my favourite interview questions. What happens when you put your hands on someone? What are all the mechanisms that could possibly be going on as you do that?
Oh, you nasty sod! Even I wouldn't ask that.
Well, it's my belief that if you put your hands on someone to assess them, you should know what are the possible mechanisms underpinning what you're doing. And if you don't know those, you shouldn't be doing it. So to say that nothing is happening is ridiculous. It's like saying, well, there's nothing happening when I'm sat in with the patient. I might not be saying anything, but they're observing me, they're looking at me, they're evaluating their surroundings. There's something going on. It's just not possibly tangible right at that time, but there's definitely something going on.
Sure, yeah, and it might not be then making any difference to that person's presentation, but that doesn't make it literally nothing, does it? What about what I would argue a stronger counter to regular use of manual therapy that I wouldn't necessarily throw towards you for knowing your position on things, but for people that use an awful lot of manual therapy and I would say overuse and abuse manual therapy, there is I think a valid critique that is that if you have active strategies that can achieve at least the same thing, if not better, then just doing it out of obligation or doing it because it suits your model of practice, or if I'm being cynical, your business model. I admit that is a frustration of mine, and one of the stronger arguments against regular use of manual therapy. Is that something that you feel has some credence, that active strategies over passive ones for the same gain is a fair point?
Hugely. Again, that escalation of care. If I can get the patient to do it, it's the patient will lead it. If it means that I have to lead that model for a short period of time, and it's a balancing act. You have that patient interaction is about who's leading who. Is it very much shared, or is there much more of a drive from the patient, or do you have to then take control a little bit to help support the patient moving forward? But you try and always step back from that. This is basic coaching. If you think about how you coach an individual, you want them to make the decisions themselves. You want them to verbalize how they're going to deal with problems or deal with and make solutions. And so I take that approach with patients. I'm trying to coach them through things, and I want them to understand their condition. I want them to be able to verbalize that back to me. And then once they can do that, they can start to interpret it and understand it for themselves. And it's their reality, not mine. So manual therapy has to be applied to help that, but it shouldn't dominate it, and it certainly shouldn't be employed straight away. You get those strategies in first before you think about trying to do anything else.
So it's supplementary. It is the true word of the adjunct.
Oh, it's part of what you have available to you to improve someone's experience of movement, and if that's probably the easiest way for me to describe it.
And with that, it might be worth us having a bit of a back and forth on this, because it might be a point in which we subtly disagree. I've got a hunch as well that no one is that good linguistically, that if a patient comes in with all the usual myths and misconceptions that society perpetuates, where there's a sense that we fall in and out of alignment. There is a sense that things that are tightened can be released by another human. There are adhesions that form in and around things, and these are myths that exist from Joe Blogs through the sporting sector. If not, they're more prevalent in sport and when you engage with exercise, because those myths become profitable and people can cash in on them, whether they mean to as charlatans or whether they genuinely believe it. Therefore, what I'm going to get to is, when someone comes in with all of those, I don't know if I'm sure that anyone's linguistically capable to untie that sufficiently so that when they do lay hands or they did a manipulation, that they would be able to undo those beliefs, and that couldn't then be detrimental to that patient. So I find myself being potentially more cautious to engage with those patients, even when I'm laying it on thick that it's not doing what they think it's doing. What's your sort of take on that?
Yeah, I think when you've got those type of individuals in front of you, you've got some choices to make, and this is about behavioural change. And there are some patients that you can, there are some patients that you can't, there are some that are going to be unwilling. And the quicker you work out which ones that those patients fall into, or the capacity to change, then you can start to select how you're going to approach it. So there'll be patients that absolutely that fits their belief system. That's what makes them tick. That's what allows them to function. Now, you as a therapist, I won't necessarily. I'll certainly try to engage in a conversation to say, well, this isn't probably the reality, but you're at risk there, because many of these patients may have been seeing someone else for long periods of time. They've invested their time, money, emotion into these treatments. And then you turn around, you see them twice and tell them that's all wrong. So you are at risk of really a confrontation, and actually for them to feel a sense of guilt about what they've been doing. They think they might have been doing something wrong. So it's very, very sensitive in terms of detangling some of that. And I think we can get that wrong by being quite confrontational about it, because we've got a very strong belief that actually that way of therapeutic intervention was wrong. So there are, without a shadow of a doubt, there are individuals, and I know stories and I've heard feedback where the application and the information that's given will be along the lines of, things being put in and out, releasing things being locked. I only heard about a locked facet joint just the other day, about patients telling me they had a locked facet joint because that's what they've been told. And we do have a real problem with that, but it's choosing your battles, really. And if you find the one that actually they're in a point of they could change here, that's how I would spend my time and energy. With the ones who are very, very ingrained, who don't wish to change, it fits their belief system, it can actually be too challenging within the environment that we have available to us.
Do you find yourself being strong-armed into certain situations where you do have to meet them halfway or go along with something? There's the typical patient, if they're particularly bolshy, they might say, okay, I get it, I don't care what it does, we clearly disagree on what you think it's doing to me, but I still want that because I've had that before. Do you find yourself having to, ethically bow out and say, look, that doesn't sound like there's a real compatibility, or do you find yourself sort of colluding with that, with the hope that you can move past it? How do you personally approach that? Because it is a dilemma, isn't it?
It is a dilemma, and I go back to my rationale for applying treatment. If I can't see a good clinical value, outcomes related, and there's the evidence for that patient in front of me suggests that manipulation is not appropriate, or manual techniques are not appropriate, doesn't matter what they tell me, we're going to have to agree to disagree. And I know they'll go to someone who will do that, but I've got my own ethical and professional a moral code to continue with, and I wouldn't actually ever really challenge that just because a patient was challenging me in that way.
No, that's fair enough. I know it's a hotbed question for us to just do a quick pass on. Do you feel that those, when money is changing hands in private practice, that those conversations are the ethical dilemmas then become even more fervent? I would argue more important, if I'm honest. But if I hear more about people being more likely to collude with it and go along with it rather than to put their foot down and say, clearly our ethos here isn't suitable, and therefore, go elsewhere. Personally, I've found myself directing business elsewhere and even pointing people to other practices for those reasons, and been called all sorts of names for it. Not by patients, admittedly. They seem to appreciate honesty, but generally, I've even referred patients to other clinics, and then the clinic haven't said thank you for the patient. They've been annoyed because they feel like it's almost a passive aggressive tactic. And weirdly, I accept it kind of is, but it was a very genuine thing. As to, I know you do these things. They wanted needles and cracks and deep frictions, and I'm not that guy. No. From what I understand, you are, and they rarely come back and say, no, you've misunderstood us. They kind of say, well, yeah, but we just don't want us to be you to say it. So so that's where I've been. I'm admitting a tail of the tape there. But do you think there is that dilemma in public and private practice and the differences there?
Yeah, I worked. I never had my own practice, and I've only ever worked and completed an evening or a couple of evenings a week. And I've always said I've never had a very good business model. In fact, when I was, I think, 4 years qualified, I was asked to leave a practice as I didn't have enough follow-ups. Well, actually, they said I wasn't creating enough business. So this was back in the mid-90s, and I remember that distinctly. I think I was asked to leave, or we mutual agreement. I left, and I have actually I've thought about this a lot, and I can understand when patients are adamant that's what they want, and there is expectation, and you're offering a business, and you're offering a service to the patients. I can see where that might go. I really can. And genuinely, they might say, well, I might house this in a treatment episode, and hopefully there's clinical rationale for everything else I'm doing. And so I do see that. I wouldn't ever want to be a really strict line saying this is totally wrong, but I do understand where it's coming from. In terms of the moral and ethical code, I couldn't do it, and I've never been able to do it. And I couldn't work in private practice because I struggle with what patients sometimes expect me to do, and I know that I might be shot down by private practitioners who then say we don't do that. I'm sure that doesn't happen across the board, but I struggled in private practice because of that. And when I was most of the patients I saw, I was seeing once or twice for advice and guidance in the vast majority of patients that I reviewed. So there's not an easy answer to that, and I think it's very individual, and I think it comes down to our own professional conduct and ethical codes towards patients. And you have to live with yourself, and you have to go to bed at night, and you're the person who you are.
At the very least, it seems a smart move to not be if you're working and straddling the sectors, then you shouldn't be a different physio in different circumstances. That's sort of a red line for me. I can understand how these things do perpetuate. I often joke if I ever, on the rare occasions that I introduce people to my accountant who's bold as a coot, I often I said to him that when he met me he had hair, because he can't, it was hard initially for him to comprehend why we had a low follow-up rate and why we'd refer to our competition, and it took for our reputation to build for what we're known for before he realised that the stance we were taking and the moral judgment we were deciding to pitch ourselves at. But a complicated one, and one that I think both of us seem to be understanding of it whilst not necessarily condoning it. It's not to smear, and we get enough grief, and maybe the hate mail will flood in on this, but if you're a private practitioner out there that feel that we're suggesting that all are the same, we're not doing that. But it's just that ethical dilemma when literal cash is changing hands rather than taxpayer funded, there's a difference there, and we accept that, and we'd love to hear from you if you feel you want to push back on any of the specifics. Do you feel then what we could argue with the new age manual therapies, such as myofascial release, craniosacral therapy, active release technique, are they a help or a hindrance to the wider conversation on these issues? Because it's a hotbed and a very emotional topic anyway. So now that we've got what seem to be the critique seems to be easier when it comes to the more historic models, because we have a base of literature. We've got a number of practitioners, yourself included, who've been on these journeys. That we say, I find myself getting blindsided a little bit by, well, that applies to manipulation, but this is different. This is a different thing. You're not critiquing it more specifically. Do you think that that's helpful, or should we take it all on its own individual credit?
I think, and I touched on this in the past, is that we have to hit a point in musculoskeletal physiotherapy as one element, that we have to get rid of all these terminologies and all these way of describing basic philosophies of care.
Right.
And it's driven because of individuals that are the forefathers of therapies, musculoskeletal physiotherapy, but I want to see an end to, and I'm a slight contradiction because I'm still a member of a special interest groups, but see an end to people describing themselves as Syriac practitioners, Mackenzie practitioners, Maitland practitioners. That it's of no value and of no use to anyone other than themselves, because they reaffirm their own position, because they spend time reading journals that talk about their own practice, and they meet people that talk about their own practice. What we really need is a very, very clear group that's transparent, where we all come together, but the groups that you want, the individuals that you want, have clear rationales for what they're doing. Again, I go back to that triangulation of evidence to then provide the debates to improve practice. Because unfortunately, when you've got these whether it's some sort of release or some sort of other therapy, then it muddies the waters considerably, and it doesn't allow for a very clear, transparent debate to move the profession forward. So until we get to a point where physiotherapy talks about musculoskeletal medicine, and that's the baseline, and we surround everything with that in terms of patient care, and we forget about describing things in terms of a philosophy, but we start talking about things with it, describing things around an evidence-based patient-led model, we're never going to move forward. We will be stuck with new therapies coming forward all the time.
No, that's I think a completely reasonable position. And am I right in thinking that the conversation we've had up till now, there is nothing that I've just mentioned, no other new age technique that doesn't fall under the same critique? It's not as if there's a gap, a blind spot that we have to myofascial release that isn't applicable to the discussion we've already had.
No, the discussion we've had about the mechanisms of what we do when we put our hands on people, every therapy that is described as a manual therapy, I think should be set up for the appropriate critique in the same way. And unless there can be a good clinical rationale, a sensible discussion around it, then it should never be used. Unless there's reasonable evidence, logical evidence from as many facets as we can possibly offer, then we shouldn't be using it. So there are going to be gaps in all of those, but it's whether those gaps can be filled with either good patient-reported outcome measures, good research guidance, and good physiology, biomechanics, physics, and be able to pull that together in a way that makes sense to clinicians. So I don't know about all those other therapies. I know very little about them, but I would like to see an end to all those descriptions, and we just talk about musculoskeletal assessment, treatments, and patient-led outcomes.
No, that sounds a totally fair place for us to wrap up as well on there, because it summarises things really nicely. I'd completely agree with you. I'm fearful that won't happen as we get some merging of the sectors. I think that makes it complicated in itself, because the badges of honour still hold some water. People want a new trick up their sleeve. People still want a new string to their bow, and that concerns me. That what used to be the idea in which things might be sold and bought on a product by product basis is a concern, because that's only going to muddy the water. I agree. But if voices like yours, and obviously we'll put it through here, that we can be consistent and we can discuss it fairly, and we're not misrepresenting things, I think is a good starting point. And honesty needs to be the best policy on these issues, because the minute that the sort of a myofascial release brigade feel that we're misrepresenting their position, is where the dialogue breaks down. So at the very least, it should be that we're coming at things and critiquing them openly and honestly, rather than poo-pooing them and not engaging them, whether that be on social media, in person, on courses, wherever it might be.
The next phase, you're right, but the next phase is to say that we shouldn't have these brigades. We shouldn't need them. We should be talking about physiotherapists who work with musculoskeletal conditions and work in an evidence base. If you get groups of people saying that, who are maybe, for your example, myofascial, then unless they can provide a valid argument for what they're doing, and then they shouldn't be involved in the debate, would be my argument. I know that would probably annoy some people that would disagree with me, but they shouldn't be involved in the debate. So what we should be having is a group of individuals who then talk about what are the most useful approaches to musculoskeletal, and that should be the framework that we use, and we get rid of these brigades and some of these small special interest groups, and we start talking about a group of practitioners that work around an evidence that is singularly supporting the patient.
A network with common values and a sensible consensus approach that you've just described would make the operational and political lobbying that might be required, or there'd be more consistency of sound bites, and there'd be a more cohesive approach. Particularly, we could argue within the Chartered Society of Physiotherapy, which I know you've tried to collaborate with and merge a lot of these things under a network, and that's a big project, a difficult one, one that I know keeps getting shelved and then reopened. I'm sure it's something that we'll chat about further, or could chat about further. But is that, if the future can't lie there, so if we didn't have enough consenting groups and clinicians who didn't necessarily view the world like we do, where this is another position where we're clearly just super well aligned on. If there wasn't enough consent there for us to democratically then reframe, remodel and reform the profession, I often use the word reform on these podcasts because I do think that's what we require. Is that a worrying sort of contentious future for us as a profession in this country?
I think that's a really good question, and I think yes, if we as a profession are unable to inwardly look at ourselves and be critical. And I think it's important to say that we certainly don't want everyone thinking the same, but
Sure.
What we want is a common framework where the debate is clear, fair, and transparent, and the dialogue is respectful. But in the end, if you, as a profession, if we're unable to demonstrate that inwardly, how do any external bodies, inclusive of patients and all our stakeholders, take us seriously going forward? And until we actually, those external partners and our patients see that there is a commonality in the way that we approach patients within that framework, we won't be able to reform or move forwards. We'll be stuck with these huge diversity of practice based on description and philosophy rather than research and patient values.
No, that makes sense, and I think that the inconsistency is a worrying sign. And I've got two final questions on that, really, small ones, and feel free to give shorter answers than the questions will be, because you know me and my lengthy questions. But generally with this, do you feel when you are asked by a friend or a colleague or someone who's outside of the physio bubble, do you know of a physio in this area? Or say a family member who lives not local to you was to say, I've got a sore back. What would you recommend? Do you personally feel confident saying just go to your GP and be transferred to physio services?
No, it would be the answer to that. I would normally direct them to somebody
more
that
specifically.
And that's not against the profession, that's against what the situation the profession is in.
Yeah.
If we look at the pressures that are put upon the profession to deliver high level, complex care in situations where the waiting lists are high, patient demographics are challenging, restrictions on the number of times you can see a patient, how often you can see a patient, means that it's not the profession that is at fault, it's the system that it works in. It means that it's not able to work at the top of its license to deliver the care that it's capable of. So if you know where there is someone who can deliver that, then I will always direct them to them. If I know that there's a service that's currently in a good position to offer effective care at the right time, then I would direct them to them.
That makes sense. I mean, it's very similar to my position on it. And I've admitted, potentially even on air before, that it is a benchmark for me in my career is if I come to a close and come to retire and I'm confident to suggest that bar it, I'm not going to be everyone, but if I was to have someone who was anywhere in the country, and hopefully if I was being grandiose anywhere in the world, certainly the Western world, where I could be confident in saying go and see a physiotherapist and they'll be able to treat you appropriately and fairly without me having some headaches and concerns when you come back to me in a couple of months. That would be a massive. That's obviously one of the main goals that we have with the Physio Matters project. Is that would be a brilliant place for me to bow out, is that there's a baseline competence and understanding and a consistency of message that we have as a profession, where I'm not worried about nonsense being perpetuated to my loved ones just because they happen to not live close by to me. That would be a real benchmark end game, and I hope that there's enough people around there that would agree with that and want to perpetuate that message and share good messages, critique bad ideas, perpetuate good ones, and that's where we'd end. I said I said two questions. The last one's even simpler. Is how many, if you had to statistically sort of quantify it as an estimate, how many patients that you see, how many new patients that you might assess on a typical month or whatever it might be, would you perform a manual therapy technique on, even if it's just as a one-off? Would you be able to quantify that as an estimate?
Yeah, I probably, again, a guesstimate would be. Again, this is sometimes the environment you work in. So when I have in private practice, it's probably because these patients are normally relatively well.
Compared to the ESP clinics that we run.
And don't tend to be in such a chronic state in the strictest sense, where the longevity of it, the sensitivity of it, I'm probably 35% more into the private practice, maybe nearer 20%, 25% in NHS would be dependent on the patient caseload.
Yeah, sure. No, that makes sense, and I know that's not a rigid number we're going to hold you to, but I just thought it was an interesting place for us to end on. I could have opened with that question, as you can imagine, but then it just seems that to tell the story ahead of that and to put it into context of the quantity, I think is useful for people to understand, particularly for yourself, who is a reforming manual therapist, someone that's willing to reform that term. Although I know that you from what I've gathered in recent years, you'd rather it not be manual therapists and not, it's, as you say, musculoskeletal practitioners, but you're in the trenches trying to clean up that camp, if we call it that, and try and move it towards a more cohesive, wider group.
Yeah, I couldn't agree more. And if by the time I retire, we've moved that forward at all as a profession, I shall retire happy.
Happy days. Lovely. Well, thank you so once again for your time. We have not touched on, and purposely not touched on, some of your really interesting work around reasoning, ESP, logic, the clinical hunch, which you've written about, which really maps beautifully onto some of my sort of personal reading that I love to do in sort of moral philosophy and that jazz. So I'm sure our minds will meet again, both on and off the microphone. But thank you so much for all that you do and for this conversation today.
Pleasure. Thank you for inviting me and giving the chance to chat it through with you, Jack.
No bother. All right. Have a nice weekend, mate.
You too.
So that quite literally was me and Neil Langridge chewing it over. Hope you enjoyed it. I certainly did. It was always great to catch up with Neil, and of course, it goes without saying, I massively appreciate his time. Please do let us know what you think. There's plenty out there to agree and disagree with, because this is a complex area in which I'd be very surprised if some of it didn't make you feel uncomfortable, if you feel like we're over trivializing certain things, or if you feel like we're showing being too critical of something that is a common practice within physiotherapy. There's all sorts of different angles in which you can critique this episode, and I really would value your attention to that. As mentioned at the start of the show, that we've got then an 8-day £1,000 course that we're giving away to patrons. It's not the only thing that patrons get. I mean, they get exclusive interviews on a monthly basis. An example of some exclusive content is via HW Matters, Heather Watson's subsidiary company, that are doing, we recorded their session at ERWCPT, sort of 90 minutes worth of specialists in a panel discussion about physiotherapy and use for work in and out of occupational health settings. Just absolutely phenomenal piece that we recorded for them. Keep using that word phenomenal, don't I? There's just lots of phenomenal things going on clearly at the moment, because I'd say if they weren't. But it's just brilliant sort of content. I would say that, but it is brilliant exclusive content. We do really save not always the best bits, but certainly the edgy stuff, the real provocative stuff gets saved and shared on Patreon and discussed out there. Not a lot of them, but as you can imagine, when it's exclusive, it means sometimes we can speak frankly and openly and share things freely without the huge consequences that come from the rest of our fully public material. So if you want a little more, and also the exclusive insight into our mentoring system within Choose Health, and the access to all of the literature that gets discussed, that's all going on there. Newsletters are now Patreon exclusive to some extent, and we will be sending out and starting a drip feed, a subsidiary, I can't say it properly, subsidiary, oh God knows, a sub-newsletter that will go out to the old mailing list. But if you want to get the access that you've long known outside of just these monthly episodes, then yeah, Patreon's the place to be. That'll keep us ticking over and keep us fan-funded. So thank you once again for your time. Thanks to Neil for this episode. Thanks to sponsors Remedy Physio, who are supporting us on Patreon, giving away all these courses that a lot of our patrons are now enjoying. If you've seen us on Twitter, people raving about these courses that they're going along for free because they throw us a few quid each month. It's ridiculous. And now £1,000 prize as well. So Thomas at Remedy, thank you so much. And also they're doing some brilliant work at the moment. If you check out their their Twitter feed at Remedy Physio, they're doing a survey to try and canvass the opinions of MSK physios, how they like to receive their knowledge, what their general consensus is on certain positions, and that's going to be invaluable data if we can get good numbers for it. So check out their social media feeds, and thanks once again to them. Please find us at TPM Podcast on Twitter. I'm Jack Chew at Chews_health. Neil Langridge is also on Twitter at Neil J Langridge, and he's running a course. I'm not even going to call it a manual therapy course because I just think it's just lazy if I did so. But he's running a course with another great character, Matt Lowe, who you'll find on our microphones for the course health coverage that we put onto YouTube. So if you want to hear a bit more from Matt, then have a look at that. And once you've seen both of you've heard this podcast, you've seen and heard from Matt, you'd certainly want to be able to go on their course, which is called Clinical Reasoning, Treatment and Management Principles in Low Back Pain, a Person-Centered Approach. It's with HE Seminars, so heseminars.com, and they are running courses in... We might be a little late for the February one because it looks like there aren't many places left, but there's a course in February in London, one in Lancashire, Royal Manchester Children's Hospital in March, and one in North Yorkshire, Harrogate District Hospital in June, and finally in Hampshire in the New Forest Hospital. I think that's down Neil's neck of the woods in September. So certainly if you enjoyed this podcast and you want to hear more from them and try and help your patients with their back pain in a really contemporary manner that does include hands-on treatment, but isn't exclusively regarding tools and gizmos and gadgets that you would hear of old, then please do have a little look onto those courses, because you will not be disappointed. I have said enough, and it's a long podcast as it is. But thanks for tuning in. Hope you've enjoyed this episode. Please do let us know what you think, and we'll hear from you soon. Find us again, I've mentioned on Twitter, but also we've got this Instagram page now, because I've still not got to the hang of it, but our new girl, Felicity Thou, has thrown us onto Instagram. There's a bit of a tester. We're also, of course, on Facebook, and we'll be doing some Facebook Live stuff, streaming from various events over the course of the year, so you've got lots to look forward to. And we look forward to engaging with 2017 with you. So you've been listening to the Physio Matters podcast, discussing physio matters, because physio matters. Bye for now.